Good afternoon, everyone. As you know, this is supposed to be the graveyard shift. But of course, today, after this fantastic conference, this is the scorching Scotch bonnet shift, where you're going to find a magician. I told you it had to be that. And all sorts of other beauties that will help us go. My name's Christopher Neville. I'm the CMO for the RNA, a long-time RNA member. I have lots of tropical experience and some family medicine in Wales. We're looking forward to playing golf more comfortably without it and coping with the deterioration as we get a bit grayer. And I hope Prakash is going to show us the way forward with all of his insights from the Shirley Ryan lab. It would help if I had my glasses on. Then we hope to be followed by the nirvana of lower limb joint arthroplasty, and I hope that you've been able to see the excellent posters that are up that give us more information on that. And consultant Nick Clement from Edinburgh, who has enormous experience in this area and over 100 papers to his credit, will give us an insight of that side of things and your recovery. Finally, the magician, Prof. Charlie Foster of Bristol, chair of the UK CMO Expert Committee for Action and Activity generally, will give us some ideas of why we should all be playing golf if we don't already know. And then finally, the godfather, who's become a roving reporter to this conference, Roger Hawkes, who founded the European Tour Performance Institute and helps dynamize Edgar in his spare time these days, will give us the view from the 19th hole, where, of course, you remember the putts that we sank grow ever longer. The drives we hit are definitely longer. But he will be rounding up this remarkable conference with its multi-layered evidence-based approach towards universally accessible golf and its holistic benefits. We'll have questions after each and every presentation because they are a little bit different. So I call on Prakash to come and start us off. Yet another economic migrant.
Thanks so much, Chris, for the wonderful introductions. I am an economic migrant. This is not an American accent. I'm British. If I did do an American accent, it would be horrific, so I apologize to the American in the audience for that, or a couple of other Americans as well. So I'm going to be talking today about playing golf with osteoarthritis, really focusing on the knee. I'm a sports medicine physician scientist, primarily a specialty called physical medicine rehabilitation in the United States. So I'm a physician, but I also do research, and I have my own research lab. So first, I want to start with a patient that many of you in sports medicine, orthopedics, or physical therapy have seen in your clinic. So this is a 67-year-old former runner who presents with a 7 to 8 month history of medial-sided knee pain. And our classic evaluation of this patient, at least in the United States, is to examine them and perform imaging studies of that patient. And then we diagnose them with osteoarthritis. Our treatment regimen, classically, is firstly to try and manage their pain with pain medications such as paracetamol and other NSAIDs. We'll talk about exercise prescriptions such as weight loss. We'll talk about physical therapy, and we'll talk about exercise prescription, which is going to be a lot of the focus of what I'm going to talk about today. And then we have injectable treatments such as steroids, hyaluronic acid, viscosupplementation, leading all the way to the nirvana of total joint replacement, Nick Clement, who will talk about total joint replacement for individuals with knee osteoarthritis. And this is our classic treatment paradigm for those of you who aren't aware of how we manage knee osteoarthritis. And I'm going to be focusing on this one piece, which is physical activity in individuals with knee osteoarthritis and using golf as a potential intervention in these patients. Before I go into that, I do just want to give a quick explanation of what knee osteoarthritis is. So when people talk about knee osteoarthritis colloquially, they often say knee osteoarthritis is wear and tear within the joint. That's classically what most of us say. But really what it is abnormal biomechanics interplaying with abnormal biology within the joint. And there's this inflammatory cascade and degradative enzymes that get released into the joint which potentiate that damage. And so we, non-operatively, because that's what I practice, our goal is to really try and decrease that inflammatory cascade through medications. There are medications that are being developed by pharmaceutical companies which actually try and target those MMPs or cartilage degradative enzymes. And we also modify the activity of our patients and ask for them to try and lose weight. But what I want to say today is that both of those prescriptions or interventions have both a biological and biomechanical effect in individuals with osteoarthritis. And then when we think more generally about osteoarthritis, we think about osteoarthritis being damage to the cartilage within the joints. And as patients place weight over their joint over time, there's potentiation of that damage over time. There's different parts of the joints, the synovium, subchondral bone, which are impacted as the osteoarthritis continues. And there's also the release, particularly from the synovium and the cartilage, of these cartilage degradative enzymes, as well as inflammatory mediators, as well as cartilage breakdown products, which potentiate that damage further. And as the patient's cartilage wears down, we get bone-on-bone motion, which leads to pain. And that balance gets tipped more towards catabolic processes as opposed to anabolic processes within the joint. So when we go back to our patient and we think about potentially golf as an intervention for this patient, or I should say physical activity as a whole in this patient, is golf safe in someone with knee osteoarthritis? How does it impact their general well-being in terms of their joint disease? And then how can we optimize engagement in the process? When we think about someone with osteoarthritis and we're going to say, go and walk the course, well, that's going to cause pain potentially. So how do we find what are strategies that we can use to optimize engagement in the sport in these individuals with knee osteoarthritis? So firstly, is golf safe in osteoarthritis? So in the US, the current recommendations are really from the CDC, and Fiona Bull definitely has more elaborate guidelines in terms of physical activity, but the most common by physicians in the US is from the CDC, or the American College of Sports Medicine, which advocates for greater than 30 minutes of moderate intensity physical activity 5 times per week. This is based on cardiac health. We don't know whether that's actually detrimental to someone's knee joint or not. So we did a study looking at physical activity and radiographic progression of knee osteoarthritis. So there's a nationally available cohort in the United States called the Osteoarthritis Initiative, where they did x-rays at baseline in individuals with early knee osteoarthritis. And they looked at objectively measured physical activity at baseline using accelerometers. And what we were interested in was, at 4 years down the line, was that baseline level of physical activity associated with radiographic progression down the line? Not symptomatic progression, but purely radiographic progression. So if we think about a patient at the baseline in this study with mild knee osteoarthritis, what factors were associated 4 years down the line with progression of their knee osteoarthritis to a moderate state only on x-rays? And this was about 1,200 patients that were included in this database that I used. And essentially what we found was that factors that were associated with radiographic progression of knee osteoarthritis was factors that are associated with the development of knee osteoarthritis, being older, having a higher BMI, being female, and having higher baseline pain. Those aren't anything novel. But what we did find was that physical activity did not lead to radiographic progression, either if it was at the very lower end of the spectrum or at the higher end of the spectrum. In addition, anyone who'd had a prior knee injury or a prior knee surgery prior to incorporation into the study did not have progression of their osteoarthritis radiographically. So I want to remind you, this was radiographics, not symptomatic progression. So then when we think about physical activity in individuals with knee osteoarthritis, well, it seems to be relatively safe structurally based on x-rays. But now what we want to know is, well, if we use golf as an intervention, how does a round of golf impact the knees? So we, as has been said many times today, we strongly advocate for aerobic exercise in our patients, and both from a public health perspective, but also from a symptomatic and disease prevention perspective. But the problem that we have with individuals with knee osteoarthritis is many patients have this fear avoidance. They're worried about actually progressing their disease or they're worried about provoking their symptoms. And there's really overall, particularly in the United States, a lack of knowledge regarding exercise, and then further, exercise in individuals with knee osteoarthritis. So could golf be the solution? There's a large amount of people over the age of 50 who have gray, as Chris mentioned, who play golf in the United States. Not Chris, of course, but the average distance, as Andrew Murray alluded to, the average distance walked in a round of golf is well over 10,000 steps, approximately 7 kilometers. And so what we wanted to know is this beneficial for individuals with knee osteoarthritis? But the caveat is that in the United States, and it's wonderful to hear all these interventions for golf and health in the United States, golf is played very differently in the United States. As this paper alludes to on the top, is that golf is really not as active a sport as many of you play in Europe. And I thought the article below, when I first did a literature review into this realm, was pretty telling. And obviously our former president was very into golf and often used a golf cart. And there was topics of whether he should use the golf cart or walk the course. And the challenge is that in the United States, the majority of rounds of golf in the United States are played using a golf cart. So that impacts the physical activity that someone gets while playing the sport. So looking at it more epidemiologically, in 1984, 45% of rounds of golf were played with a golf cart in the United States. This was 2006, and it's probably even worse now. 69% of rounds of golf were actually played with a golf cart. And this is actually from a US organization, the National Golf Foundation, where they actually found that if you played golf in 2007, you were more likely to be overweight or obese than the general population, which is totally counterintuitive to everything that I've heard today, so I apologize. But this suggests an issue in playing golf in the United States as a whole. The other trends that are also seen in the United States is that, as you can see in the top left, is that the amount of rounds with a golf cart go up. Fewer players are carrying their own bag, and fewer of them are actually pulling their own cart. And so again, this impacts the level of physical activity that individuals have, particularly level of physical activity or cardiovascular benefits someone's getting from a round of golf, particularly in the United States. But when we think about individuals with knee osteoarthritis, maybe this is an opportunity. Maybe individuals with knee osteoarthritis using the golf cart might be an opportunity both to protect their knees, engage them in physical activity, but also allow them to get some level of physical activity or cardiovascular benefit from the exercise. So what we used was actually to say, well, walking the course is sort of high-dose physical activity, and using a golf cart for a round of golf is actually lower-dose physical activity. So if we're going to prescribe exercise, maybe we also need to think about prescribing the golf cart in a specific subset of individuals, particularly with knee osteoarthritis. So again, how do we appropriately prescribe golf for individuals with knee osteoarthritis? So in my lab, we use this idea of a stimulus response framework. This is this idea of, instead of a cardiac stress test where you get individuals to walk on a treadmill, you look at ECG changes to stratify risk for the development of coronary artery disease, we actually do a stimulus response framework that we've coined the phrase a cartilage stress test. So we get individuals to walk on a treadmill, so we load their joints, and then we measure certain biomarkers of cartilage stress in their bloodstream in real time using an IV. And studies have shown that this sort of approach, where you measure these biomarkers related to cartilage acutely and measure them serially, it has some diagnostic or prognostic value. I apologize, I look a lot younger there. I didn't have kids at that time, so that was a bit different. But the unique capacity of this methodology is that it is cartilage stress response. We can acutely measure that response to loading or exercise, and it also allows dynamic assessment. So using this methodology, can we be fortune tellers for someone's osteoarthritis? Can we tell them how a particular exercise is actually impacting their disease? So what we did was we got individuals who were golfers, regular golfers who played golf about 3 to 4 times a week but had knee osteoarthritis. And the first round, they would walk the course. And the second round, they would use the golf cart. And we randomized which one they did first. And every 9 holes, we would essentially take blood from them. We'd ask them their perceived exertion, we'd ask them their pain score, and we'd also do continuous heart rate monitoring and step counts on these individuals. So the first thing to say is that, as you would expect, so the red bar is when they walked the course, they actually had significantly higher amount of steps, as you would expect when they walked the course. the rating of perceived exertion, so how much that exercise, they exerted themselves during that exercise, was significantly higher. And their max heart rate that they achieved during that round of golf was also significantly higher. But then when we looked at specifically things that are pertinent to osteoarthritis as a whole, their pain during the round went significantly, and actually was clinically significantly higher when they walked the course as opposed to using the golf cart. There's certain biomarkers of inflammation went significantly higher, particularly when they used the golf cart when they walked the course throughout the round, as opposed to using the golf cart, which was only at the end of the round. And then a biomarker associated, which is anti-degradative, IL-1RA, which is, IL-1 is a degradative inflammatory mediator, and IL-1RA is an antibody to that degradation. That anti-degradative marker actually went up when they used the golf cart as opposed to using walking the course in this particular study, in this particular cohort. The biomarker, the primary biomarker that we measured, which I won't go into too much, is a biomarker within the extracellular matrix of cartilage called COMP. And essentially, COMP is a biomarker that transduces the mechanical signal anytime any of us walk on our cartilage. It transduces that mechanical signal from the outside of the cartilage to the chondrocyte, which is the cell within the cartilage, and maintains that cartilage health. So if you measure a lot of COMP in the bloodstream of a person, it usually means there's a lot of stress on their cartilage. And what we found was when they walk the course, there's a significant increase in COMP, which is this marker of cartilage stress, whereas we only saw that increase when they used the golf cart around the course. The other thing is cardiovascularly, we saw that the average round duration was lower, so there is a time effect when they use a golf cart as opposed to walking the course, but it's still almost 4 hours that they're out on the course. And the level of moderate vigorous intensity activity was higher when they walked the course. But if we think about fulfilling physical activity guidelines, they easily did that when they used the golf cart. So it's about 30% of that 4 hours, they're in that moderate vigorous category, which is very, very good to see. The other thing that we also measured was feelings of well-being, which can be measured by a hormone called beta endorphins, which many of you probably heard. And we found when they walked the course, there was a significant increase when they walked the course as opposed to using the golf cart, which is a good finding. But the only thing that really mattered to our players was that their scores were better when they walked the course as opposed to using the golf cart. So in conclusion of this specific study, we found that walking the course did have a stress effect on the cartilage. There was an increase in inflammation, but you saw that whether they used the golf cart or not. And there was an increase in pain. Whereas when they used the golf cart, there was no increase in pain overall significantly, and there was less stress on the cartilage. But they did not get as much of that cardiovascular benefit. And they also didn't have as much endorphins when they used the golf cart. The one thing I will say from this study, and just hearing colloquially from some of the people, or sentiments from some of the people who did the study, there was this idea that using the golf cart could allow physical activity engagement, particularly in those who are more sedentary to begin with knee osteoarthritis. And being out on the course, as we've talked about several times today, does also allow some social behavioral well-being that we, particularly some of our subjects, reported. So now we've talked about how it impacts the stress of the cartilage of our patients. Now I just want to talk about golf for general health. Think about individuals with disability. And no better way to study that was COVID-19, where individuals were not, particularly in the United States, where we were much more conservative in terms of golf, there was no idea of, no allowance of people being out on the golf course for quite a long time. And so what we found, and this may be quite a low font, what we found was that individuals decreased the amount of golf, in individuals with disabilities, which osteoarthritis is considered that, individuals with disabilities had a decreased amount of playing golf in the United States, based on a survey study that we did in individuals with disabilities. But then when we looked at how not playing golf impacted their physical health, mental health, quality of life, and social isolation, the red being very highly reported, we found that overall, these individuals with knee osteoarthritis and other disabilities had a high amount of, high reduction in physical health, mental health, quality of life based on their self-report. So playing golf does have a lot of benefits for individuals with knee osteoarthritis and other disabilities that we've certainly got across in this study. Finally, I just want to talk quickly about usage of technology for individuals with knee osteoarthritis. And I remember Fiona Bull mentioning that yesterday, of using novel technology to engage people with knee osteoarthritis. And one particular study that we're doing actually uses some standard of care things that, as a non-operative practitioner, we use for people with osteoarthritis. We prescribe things like braces, orthotics, change footwear. We can do gait modifications through physical therapy. We have assistive devices, which I consider the buggy to be that. And we also advocate for weight loss in our patients as biomechanical treatments for knee osteoarthritis. But one study that we're actually doing where we're partnering with an industry collaborator is a novel medial unloader brace. So many of you have probably heard of medial offloader brace, where it takes pressure of the inside of the knee joint in individuals with knee osteoarthritis. And we were partnered with this company where you probably can't see it, but there's a sensor on the lateral part of the knee. So what it does is that sensor actually provides data which goes to a cloud, which a physiotherapist actually monitors and provides the patient feedback in terms of exercises that they can engage in. So when they're out on the golf course, for example, that individual can actually monitor them, and particularly their angular change or their gait while they're out on the golf course. Then that, as I said, that sensor data actually is reviewed by a physiotherapist or a physician, and then that is then fed back to the patient. And then that patient can then engage in those exercises before they go out onto the course. And this type of approach has actually, we found, has actually led to 20% less dropout in terms of using a brace, improved functional status in our patient compared to the standard of care brace, reduced pain, and also improved engagement in physical activity and sport, golf being one of those particular sports. So the take-homes from my presentation is to say, in individuals with osteoarthritis, golf seems to be somewhat safe, particularly in terms of walking exercise versus using a golf cart. And it's a moderate intense physical activity in individuals with osteoarthritis as well. There's a multitude of health benefits in these individuals. And I think looking for novel avenues and strategies to aid individuals in playing the sport and engaging in the sport could be the future. Obviously, we don't have long-term impact of some of these studies, and that's something that we're looking to do going forward. And the last thing I will say is that when we think about golf prescription, it's treating every person as an individual and not a one-size-fits-all approach. Not every patient that I see wants a brace while they're playing golf. Not every patient that I see will want to walk the course as opposed to use the golf cart. It's individualizing that prescription, which I think is the best way forward, particularly in individuals with knee osteoarthritis. These are my collaborators. This is my lab. So if any of you ever come to Chicago, I'd love to give you a tour, meet many of the team that I work with, one of which is here. And finally, I want to thank the Godfather, who's sitting over there, because without him, I wouldn't have even thought about this stream of science. And Dr. Press is also here from New York. But without Dr. Hawkes, I definitely would not have engaged in the science, and I'm really grateful for the opportunity to present today. Thank you so much.
Any questions? Wait.
Some potential confounders to walking versus golf cart studies, and that is in the U.S., there are areas of the course which are blocked off. Cart path only, around the area around the tees, the greens, and increasingly golf cart technology has shuts the cart down if you wander off into the trees.
Right.
So there's that, and each course may have different policies that might affect the real world implementation or understanding of these. And the second is, I would argue that the social interaction of players playing with a buggy or a golf cart is much diminished than walking down the fairway. There's less interaction.
That's a great point. Yeah, we didn't study that in our study. And I will say to your point, there's a number of studies which are looking at the novel golf courses in the U.S. Most are thought about with the golf cart in mind, not walking the course. And there's other issue, like even the study that we did, the owners of the golf course actually were worried because people are going to play rounds without paying for the golf cart. So there's also golf clubs or golf courses make money from using a golf cart. So that's one of the other big challenges we have with that. Thank you. Yes?
Did you ever think about using exoskeleton as we use in skiing?
Exoskeletons, great point. So my hospital actually has developed exoskeletons specifically for that. We haven't used that for golf, but that would be a great next step. And I think that we've never actually thought about it in golfers, but that's a great idea as well. Any other questions?
Right. Thank you very much.
Thank you.